All right, it is about 2 minutes after the hour, so I think we'll go ahead and get started as more people join us. Good morning, good afternoon, good evening, depending on where you're joining us from today. My name is Michael Gluck. I'm a vice president at Academy Health. Academy Health is the nonpartisan professional home for health services, systems, and policy research in the United States. And like the Alliance for Health Policy and Systems Research at WHO, we believe that better evidence leads to better health, but that too often research is disconnected from the important healthcare decisions that affect people's lives. So we see Academy Health's role as bringing people together with the ideas needed to close that gap. Part of how we do that is by trying to learn from the experience of our peers around the world. And we think the emergence of AI and its implications, both for healthcare and health research, presents the perfect opportunity for this type of global conversation. And we're really grateful to be able to collaborate with our partners at the Alliance in bringing this important conversation to you today. If we could go to the next slide, I'd like to start with a few housekeeping items. We are recording today's session, and we will make that recording available when it's ready. You'll get a link to that. Also, we are trying out some live AI-based language translation between English and Spanish today. If you're using that option, there may be a slight delay with the translation, so we ask for your patience. And we also recommend that you not mute your audio. There's also live captioning available, but that is without translation. We look forward to your questions for the discussion portion of today's webinar. We ask that you use the Q&A feature of the Zoom platform to submit your questions. And if you could include your country and organization, that would be helpful. You also have the option of upvoting questions you would like to prioritize. If you encounter any technical issues, we ask that you reach out to Julia Lofreda at the Alliance, and her email is here on the slide. And lastly, I just wanted to note that this event adheres to WHO's Code of Conduct to prevent harassment, including sexual harassment. My main role here today is to introduce our moderator, who has been a good friend to Academy Health, particularly in our efforts to understand technological innovations affecting our field and also in furthering our own commitment to health equity. Dr. Ivor Horn is the founder of Undaunted Health. She previously served as Director and Chief Health Equity Officer at Google and Chief Medical Officer at Accolade. Prior to that, Ivor was a professor of pediatrics at the University of Washington School of Medicine. She is an expert in the application of technological innovation, including generative AI, to healthcare, with a particular focus on equity. Ivor also serves on the boards of Boston Children's Hospital and Accolade. And with that, Ivor, I will turn it over to you.
Thank you, Michael. It is my pleasure to be here, and I, like you all, are looking forward to the discussions and the presentations today, because the great thing about this group is the opportunity to learn. I want to go, if we can go to the next slide, I just want to do a quick run through of our agenda. We will start, I will mention the names of our presenters and introduce our speakers. Then we're going to have presentations and reactions. And I like to say presentations and comments. And we all know what that feels like in meetings when we're having academic meetings. And the thing that we're going to talk about today is what's really great about this is we're going to talk about how we apply AI and how we implement AI in both evidence generation and integration around policymaking and practice, as well as individuals in the workforce use of AI as we think about it in the context of health services research. We will then open up, we will ask you to give comments, as Michael mentioned, to put your questions in the chat and add your questions as we go along, and then we will have a discussion section. where we will speak with the presenters around the questions that you've put forward. So please add your questions, and then we'll have closing remarks. Um, I'm going to start by introducing Kumanan Rasanathan, who will from the Alliance, who will then share a few words and do some level setting on the presentation. Our other presenters will be Dr. Heather Ames, Dr. Amir Takian, Dr. William Hoyas, Keisuke Nagagawa, Bianca Frogner, and Roman Shu. And I'll turn it over to Kamana.
Thanks so much, Ivor, and good morning and good afternoon to colleagues, wherever you are. It's our great pleasure at the Alliance for Health Policy and Systems Research to do this webinar today with our friends at AcademyHealth, which is, of course, the body in the United States that looks at the sort of work that we look at globally here at the Alliance, which is a hosted partnership at the World Health Organization. When we think about artificial intelligence, often it's a very polarizing conversation, whether that relates to health service delivery or health policy, or whether it relates to our broader lives. There's one camp that often are the utopians who feel that artificial intelligence will solve all of our problems, will lead to the promised land, to access and equity. And then there's also a significant camp who are worried about dystopian futures, who are concerned that artificial intelligence will achieve the singularity. We'll have a matrix-like scenario of being ruled by our digital overlords, and this will be disastrous for equity and for access and people's ability to live healthy lives. We shall see. We are in a time of tremendous change, and no one can deny that digitalization and artificial intelligence is one of the many transformative trends reshaping our societies at rapid pace. And sometimes we almost reel at how fast our societies are changing, and health systems are struggling to keep up. Often they're reactive, they're not anticipating the future and themselves shaping the future. So I think today's webinar is very timely, where whilst there is a lot of focus on the role of artificial intelligence in health service delivery itself and being the object of health systems research, less often are we thinking of artificial intelligence as the subject for health systems research in terms of its use through the whole research cycle. So I'm delighted that we can have this discussion today with a group of very learned colleagues who have so much to contribute on the different dimensions of this issue. We're also delighted that AcademyHealth itself put out a brief report recently on the use of AI in health services research. Here at the Alliance, we're also working on a manual to guide people around the use of artificial intelligence in health policy and systems research. And for us, the sort of questions we're considering, which we will consider today, range from what is the role of artificial intelligence in knowledge production and evidence generation, including agenda setting? What is the role of artificial intelligence in evidence synthesis and the use of research in the use of evidence to inform and shape policy and practice? And what is the use of artificial intelligence for capacity strengthening in research ecosystems themselves? I think there's a lot that we have to consider. It's already being used. People are going ahead, but often this isn't being done in a systematic way. One of our overarching priorities is, as we said, how do we shape the use of artificial intelligence towards equity and away from inequity? Often new technologies, there's a lot of excitement, but they're accessed first by those who are more privileged. There are overarching issues for equity around the use of artificial intelligence, concerns around privacy, around safety, around security, around proprietary capture. those issues are particularly acute for marginalized populations and also for our main constituency of researchers in low and middle income countries. So we're very much looking forward to the discussion today, and we feel that our global community, whether in the United States or elsewhere, has so much to consider, so much to contribute for the use of artificial intelligence to improve health equity, both by the practice of health system research, but also in shaping our health systems towards the utopian futures we hope for and away from the dystopian futures we fear. So back to you, Ivo, and very much looking forward to the discussion.
Thank you. Looking forward to the discussion as well. If we could advance the slides, and I just want to introduce Dr. Heather Ames, who will be presenting, and then we will have Dr. Takian, who will be the reactor. So Heather, please take it away.
Thanks so much. Yeah, I'm really happy to be here, everybody. My name is Heather Ames. I'm originally from Canada, but I'm now working at the Norwegian Institute for Public Health. I'm going to present today on how we use AI for evidence generation and evidence synthesis, and how we have built acceptance for this and trust in machine learning within the systematic review section of our institution. Next slide, please. I also really want to acknowledge that this work is not me on my own. This is a massive team, not massive, but big for us. I think we've been about 10 or 11 people since 2020 working on the implementation and evaluation of machine learning for evidence synthesis in our group here. I am not an AI or machine learning specialist. I am an anthropologist working in health systems and qualitative research with systematic reviews. So this was a new field to me in 2020 when I started. And the end work that I will present today is an implementation guidance document for other machine learning naive groups who would like to start with this type of work. Next slide, please. So today, during this presentation, I'm going to give you a brief overview of the work we've done since 2020. We're going to try and squeeze this all into the following 9 minutes. I am going to tell you a little bit about the machine learning team and how we implemented machine learning and AI into the way we work with evidence synthesis. So we are a commissioned-based group where we receive commissions from the Norwegian government and then provide evidence for the Norwegian government or the WHO, for example, Africa CDC, WHO Afro, on different questions that they need to answer for guidelines or policy. Next slide, please. So what is the machine learning team? The machine learning team started in 2020. I went on maternity leave in 2019. There was no machine learning. I came back to the office 6 months later, and there was machine learning. It came very abruptly and quickly. And this came because, mostly due to the COVID-19 pandemic, we were asked to not only do our current work, but also synthesize evidence for decisions around the COVID pandemic. So this meant there was more available evidence and more questions we had to answer, but a narrowing window in which we needed to do it. So the objective of the machine learning team at our institute was to produce evidence faster, without compromising quality, using off-the-shelf products. So we're a little bit different in the fact that we don't have programmers, we don't make software, we don't innovate AI or ML. We were using and identifying products that we could use. So we worked mostly with Epi Reviewer from the University College London, Robot Reviewer, which is a risk of bias tool, OpenAlex, which is a neural network scraper to help us find research, and more recently, large language models like ChatGPT. We've had 3 main focus areas for the team, and these work in tandem. So we have looked for innovations in the field that we could use, off-the-shelf products. We have brought those into our institute and into the way we work and evaluated them against our workflows and how we work. And then we looked about the quality that we received working with the tools and how we experienced working with the tools. If we found that a tool was promising and quality remained good or high, then we built capacity around the tool within the machine learning team, and then we implemented the tool into our working group. Next slide, please. So we had to do in-house testing and evaluation to make sure that the off-the-shelf tools we were choosing to use actually fit our needs. And this is because we answer a very broad range of systematic review questions from multiple commissioners. So we don't just do effect reviews. We work on social welfare issues. We work on health technology assessments of medical products or organizational changes. We have a very broad range of questions. So we needed to make sure that these tools that are mostly tested in more specific medical contexts would fit our workflows and our types of questions. And we did this to build trust amongst our employees that these off-the-shelf tools have been tested in-house, and we can say that they maintain the high quality that we produce while allowing us to be more effective or more efficient. And in order to do this, we had to build knowledge within a completely machine learning naive team. So we learned through doing in the beginning. I'm sure we made a lot of mistakes. We eventually assigned each team member responsibility for a tool or process. So for example, one machine member would be assigned to become our expert on ranking algorithms. So a ranking algorithm is used in study selection for systematic reviews, and it just reprioritizes the title and abstracts that you're screening into the order which seems most relevant based on the decisions you're making. So it helps you get to relevant things faster. And then we use this train the trainer approach to train other team members and create our teaching materials. And then we created a syllabus where we would onboard new team members, where they would go through the syllabus and then have check-ins with different team members each week to learn a new skill or function. And as we all know, this field moves incredibly quickly. So we attempted to keep up to date by using this Open Alex search function that can automatically update searches for you. And then we screened the automatically updating searches once a month to see new innovations that were coming into the field. And we also maintained collaborations with other institutions or organizations who were working with machine learning and evidence synthesis in different areas, like the Social and Welfare Group in Denmark and the Epicenter as well. Next slide, please. We then did these evaluations. A lot of them are available as open access articles if you're interested in reading them. And then we had to train our employees, because it's not enough just to have sort of 5 employees from 75 doing this. We had to train everyone. So we developed training materials based on functions. We felt it was very important to explain the conceptual side of the functions so that people could understand how they were impacting their choices, as well as a step-by-step how-to on when to use the function. And each machine learning team member became a contact for peer support for a team that needed help. And this peer support really gave a low threshold and allowed members to access support easily. Next slide, please. Adopting machine learning also made us see that we had to change the way we work. And this was actually unanticipated. We didn't think this would be such a huge area where we had to change. We became much more intensive in the way we worked in teams. We worked on fewer reviews at a time. We worked simultaneously across many review steps. And it changed the study selection timeline, which also hugely impacted our communication with commissioners and what we could tell them when. And this led to us adopting much more intensive projects that used more agile team methods. Next slide, please. So then implementation. So we did all this, we developed the training materials, and in our work, we really aimed for our employees to feel comfortable using this. And we really wanted to set the change message and expectation early. So the slide shows the message that we had for our employees, and the red was the really important, crucial part, that machine learning can make us more effective and efficient, but it is mostly based on our work and how we decide things. So our expertise, experience, and critical thinking are a crucial part of the process. We wanted to foster acceptance and build trust through these in-house evaluations and training. We had to manage expectations about what it could do or not do. And we had to be open to team members or workers that were hesitant to adopting machine learning. And I'll go in, you can read more about that in the implementation guidance I'll talk about. So, next slide, please. What did we learn? We had a number of facilitators, so active leadership support was crucial. We had to have a clear mandate. We had to have protected time. When you work in a commissioning environment, you're always busy, and our leadership was good in the beginning at really protecting our time so that we could explore new things and we were allowed to fail. There was no expectation that everything we tried would be successful. So we had a nice little protected sandbox. We needed an active machine learning team that was engaged and stable. The stability of the team was very important. We had to work well together. We had to find out who our early adopters were and get them on board. We really had to make sure that all of our teaching and guidance used plain language and really give a low threshold for support and questions along with these in-house evaluations. We also did face a number of challenges. So it was fairly easy to get everybody onboarded and trained for how to use things, but it was difficult to train for independence. And this is because this is a products that they would actually be using sort of intensely for 3 to 4 weeks and then not use for 3 to 4 months. So that was a challenge for us. It was a challenge to address some of the hesitancy that we faced, and we had varying adoption rates across the different areas of our group. We also had incorrect use of the machine learning, so where we weren't saving time. A big thing we faced was that because we were fairly early adopters, we actually didn't know how we should report this machine learning in our reports transparently. We also had very heavy workloads on other projects. This was the COVID pandemic, and so we weren't always able to prioritize this work. And something that the team felt was important was getting all of our workers to be reflexive around how their decisions impacted the algorithms we were using. So they were part of it. Next slide, please. So this raised some other questions. What do we do about, for example, equity? We work with partners in low and middle income contexts. We need them to have access. A lot of this costs a lot of money. So we attempted to use mostly open access or lower cost issues that were not a black box where we could access the algorithm. We had to consider our positionality and bias, especially in how this interacted with our screening techniques or how we worked. We had to consider human in the loop versus the machine on its own. This issue of transparency and reporting and how much can we do, how much can AI do, how much can the large language model do became an issue. And we had to build commissioner and publisher acceptance for what we were doing. Next slide, please. So if you want to know more, the whole project completed with this implementation guidance document for other groups who want to implement something in a machine learning naive environment. And we're hoping to publish this as an article shortly as well. So that's all from me. Thank you very much for your attention, and we will pass on to the reactor. Thanks, everyone.
Ivor, do you want me to go first? Go ahead, or you want to?
Go ahead, Amir.
Okay, thank you very much. Thanks, Ivor, and thank you very much, Heather, for a very interesting presentation. I found it very useful, specifically because it moves the conversation of artificial intelligence as tools and technical issues to the level of institutions, socio-technical issues, governance, and real practice. So I have a couple of things to say. My first reaction is that this is a story about the organization reorganizing itself in response to a policy need. For instance, how to get evidence to decision makers in a much more timely way. What comes through clearly is that the progress did not happen because the tool was available. Your group actually built a condition around the tool, a clear mandate, they defined the roles, and then training, evaluation, and ongoing support to make it work, actually. And this is very interesting. For me, that's the key lesson for health policy and system research, as well as evidence institutions. Integrating AI is an organizational change process. That's clear from your presentation. And ultimately, a governance decision. So it requires leadership. You had a good and great leadership, supporting leadership, and choices about roles, accountability, resources, and adaptation, and how the institution will support and oversee new ways of working. In particular, the leadership support is crucial to progress, as it was obvious in your experience. The second thing I want to say is I learned from your presentation that the impact of machine learning was not only faster screening, it actually changed the workflow and the way teams work together. You showed more intensive teamwork, more overlap across stages of the review processes, and changes in timelines and communication with commissioners. This is a very important point for our field of health policy and system research, because it reminds us that artificial intelligence adoption always has a human and organizational consequence. People have to work differently. Teams need different rhythms, different handoffs, and different expectations. In health policy system research, this also raises the deeper tension. The question is not only whether the algorithm classified correctly, but whether the process still preserves interpretive depth, contestation, and context. So, the implementation question is not just, does the tool work, but actually, what kind of evidence work are we preserving, and what might be compressing? The third point, especially it is important for the low middle income countries when the alliance is focusing on, is the issue of capacity symmetry, data sovereignty, and tool choices. As institutions begin to integrate AI, the question is who can use them well, and under what conditions, and with what degree of control over data, infrastructure, and methods. If adoption depends on highly specialized capacity or proprietary system, there is a risk of reproducing existing asymmetries between institutions and partners, specifically in the global south. Thus, the health policy and system research and policy institution tool choice is also the governance choice, which affects who participates, who benefits, and who retains control over the evidence processes. My fourth point is what I found specifically compelling was the use of embedded process and performance evaluation within the group's own workflows. This is a very policy-relevant contribution. Rather than assuming value, your team generated local evidence on feet, quality, and time saving in your own setting. Trust is built when individuals can see and in their own context what improves, what does not, and what trade-offs are involved. For many institutions now considering AI integration, this is probably one of the most transferable lessons. The lesson is build an internal learning loop. Test, document, adapt, and communicate the findings internally. That kind of local evidence can do a lot to support acceptance and trust, which is crucial for our job. And my final point is on the closing question you raised about transparency, equity, bias, legitimacy, and in one word, governance. I think they are exactly the right questions, and they are now central for health policy and system research community. How is AI use reported? How is bias assessed? How trust to these tools and their outputs, and under what conditions? What does this mean for partnership, specifically with low middle income country collaborators and institutions that may face different infrastructure, capacity, governance, and reality? These are the governance questions that for AI integration. This is also why your presentation connects so well to the broader work that we are doing at the Alliance to prepare a manual for the use ethical, as what Komaran mentioned, ethical and good governance of AI in health policy and system research. What you have presented is a practical implementation experience. The next step for the field is to translate these experiences into clear framework for responsible use, frameworks that help institutions make decisions not only about efficiency, but actually about accountability, transparency, fairness, and legitimacy. So, finally, overall, I think this presentation is valuable and very much precious because it gives us something more useful than optimism or caution alone. It gives us an institutional roadmap, so practical lessons, real constraints, and the right questions for what comes next. So Heather, thank you very much for your wonderful presentation and excellent work you have been doing. Over to you. Thanks.
Thank you so much, Amir. And yes, Heather, amazing presentation. I am looking forward to the questions. There were so many wonderful nuggets to take away from that. And Amir's reaction was very powerful. I think the importance of governance that I hope we can talk about in the Q&A comes up. Next, we will have Dr. Hoyas, and Dr. Nakagawa will be the reactor. So I'll...
Okay, buen día.
Good morning. I believe we've encountered some issues with the translation. I'm uncertain if you would prefer to use the translation system or if I should rely on the live interpreter I have beside me.
Well, I think that the interpretation is working now, so we can try, but we will let you know if it's not working. Thank you very much.
Okay. Muy bien. Bueno, gracias por la invitación.
Very well.
Quiero agradecer a
Well,
todos
thank you
por
for the
esta
invitation. I want to thank
oportunidad
everyone for this opportunity
contarles un poco
and tell you a
sobre el
bit
uso que
about how
hacemos
we
de
use
la
artificial
inteligencia
intelligence in El
artificial en El
Salvador.
Salvador. Mi nombre es William Hoyos, soy médico de familia.
My name is William
Tengo
Hoyos.
formación en
I am a family
informática
physician.
médica y he
I
sido
have
profesor
training
de
in
medicina
medical
familiar durante
informatics,
algunos años
and
en
I
la
have been a
universidad.
professor of family medicine at the
Antes de hablarles
university
sobre
for
nuestros
several years.
avances
Before I discuss our
incipientes
early progress in El
en
Salvador,
El Salvador,
I want you to
quiero que
understand a bit of
comprendan
the
un poco el
context that has
contexto
driven us to
que nos
innovate
ha
in the use of
impulsado hacia
artificial
innovar
intelligence.
en el uso de la inteligencia artificial. La siguiente diapositiva, por favor.
Next slide, please.
El Salvador es un país muy pequeño.
El
Tiene
Salvador is a
6.4
very
millones
small
de
country.
habitantes
It has approximately
aproximadamente
6.4 million
y
inhabitants,
es el
and it
país
is the
más
most
densamente
densely
poblado de
populated country
América.
in the Americas.
El 24% de la población está por
24% of the
debajo de los
population is
14
under
años
14
y
years
un
old, and
67%
67% of the population is of
está en
working
edad
age.
productiva. Es el país más pequeño de
It
América
is the
Central
smallest country in
y
Central
esta
America.
estructura nos hace pensar en que debemos
And this structure
aprovechar
leads us to think
la
that we
gran
must
cantidad
take
de nativos
advantage of the
digitales
large
y
number of
jóvenes
digital natives
para
and young people
subirnos a la ola
to
de
ride
la
the wave of
inteligencia
artificial
artificial.
intelligence,
No desde una perspectiva de
not from a
miedo, pero sí
perspective of
de una
fear,
perspectiva
but from a
de la
perspective of
regulación y el
regulation
uso
and its
consciente de
conscious
ella
use
dentro de toda la
across the entire
población.
population.
Sin embargo, debemos ser
However, we
honestos.
must be
Somos un
honest.
país
We are a
joven
young
en el ámbito
country
de la
in the field of
inteligencia
artificial
artificial,
intelligence,
mientras que algunas
while some
economías
economies have been working
llevan
on this for
decenas
decades.
trabajando en esto, de años. En El Salvador estamos iniciando nuestro camino,
In El
pero
Salvador, we are beginning our
esto no nos
journey,
detiene. Por
but
el
this does not
contrario,
hinder us.
nos da la
On the
oportunidad de
contrary,
aprender de las
it
mejores
provides us with
prácticas
the opportunity
internacionales
to learn
y
from international
construir
best
desde una
practices
perspectiva que priorice
and to
la
build from a
ética,
perspective that
la
prioritizes
transparencia y el
ethics,
beneficio de nuestra
transparency,
población.
and
La
benefits for our
siguiente.
population. Next,
Si vemos un poco la adopción de la inteligencia
if we
artificial
look
en El
at AI
Salvador,
adoption in El
estudio
Salvador,
reciente del
a
año
recent
pasado
study from
realizado
last
por
year conducted
Microsoft
by
nos
Microsoft
dice que solo un
tells us that only
14.6% de la población
14.6% of the
está haciendo uso
population
de la
is using
inteligencia
generative
artificial
artificial intelligence,
generativa y que un
and that
16.2% de las compañías
16.2% of
del
companies
país
in the
la
country are
están
implementing it
implementando en
in
sus
their
flujos de
workflows.
trabajo. Esto nos aleja mucho de
This places
los
us far
resultados
from the
que tienen
results
países
observed
de
in
la
OECD
OECD. Sin
countries.
embargo, nos hace pensar de una manera
However, it makes us
optimista
think
que vamos
optimistically that
creciendo
we
de
are
una
growing
manera
consistently.
consistente. El siguiente.
Next,
Podríamos hablar con un poco de orgullo, no
we
porque
can speak
seamos
with a bit of
pioneros, pero
pride,
sí
not
vimos la
because we are
necesidad de
pioneers, but because we
establecer
recognize the
límites
need to establish
regulatorios y
regulatory
fuimos,
limits.
justo el día de hoy se cumple un año
As of
de
today,
haber
it has been 1 year
lanzado
since
la
we
ley de
implemented the
uso de
law on the use of
inteligencia
artificial
artificial en El
intelligence in El
Salvador.
Salvador.
Fuimos el primer país de Latinoamérica en tener un
We were the first
marco
country in Latin
regulatorio dentro
America
de
to establish a
América
regulatory
Latina.
framework, and we
Y
wanted it to be
quisimos
firmly
que
based on the
estuviera
principles
muy
that guide our
fundamentado
approach.
en los principios que guían el enfoque. En primer lugar, promover el desarrollo ético y responsable de los sistemas de
First,
inteligencia
to promote the
artificial,
ethical and responsible development of artificial intelligence
transparencia en los
systems, requiring
algoritmos y la
transparency in
protección de los
algorithms
datos
and the
personales.
protection of personal
En
data.
segundo lugar, se mandata que los sistemas de inteligencia artificial de
Second,
alto
it
riesgo,
requires that
en
high-risk
este
AI
caso los de
systems,
salud,
in this case
pasen
those in
por
health,
evaluaciones de impacto
undergo
obligatorias
mandatory
antes
impact
de su
assessments
despliegue,
before deployment,
especialmente cuando afectan
especially
áreas
when they
sensibles
impact
tal y
sensitive
como les
areas
dije, la salud, la
such as health,
educación y los
education,
servicios
and public
públicos.
services.
Para nosotros, como Ministerio de
For us,
Salud,
as the
esta
Ministry
ley
of Health,
representa un
this
marco
law
de
represents
referencia
an
invaluable.
invaluable reference framework.
Nos permite implementar soluciones de
It
inteligencia
allows us to
artificial
implement
en
AI
salud
solutions in
con la
healthcare
seguridad de que
with the
existe un
assurance
entorno
that there is a
regulatorio
regulatory
que
framework
protege
that
tanto a
safeguards
nuestros
both our
pacientes
patients
como a
and
los
healthcare
profesionales de la
professionals.
salud. Además, la ley contempla la creación
In
de
addition,
programas
the law
educativos
provides for the
y de
creation of
capacitación
educational and training
financiados por
programs
el gobierno
funded by the
para
government
desarrollar el
to
talento
develop
local
local
en
talent in
tecnologías de
artificial
inteligencia
intelligence technologies,
artificial, reconociendo que la formación
recognizing
del
that
recurso
training human
humano es
resources
tan
is as
importante
important
como la
as the
tecnología
technology
misma.
itself.
Si bien estamos viviendo
While we are
una
living in an
época de
era of
consumo de
consuming
inteligencia
artificial
artificial,
intelligence,
El Salvador quisiera
El
convertirse
Salvador
en un
aims to become a
productor de
producer
inteligencia
of artificial
artificial para
intelligence
su
for its
propia
own
población.
population.
Quiero destacar un punto crucial. Optamos
I
por
want to
ser
highlight a
pioneros
crucial
en
point.
regulación,
We
no
chose
porque
to be
tuviéramos
pioneers in
toda la
regulation,
experiencia,
not because
sino
we had all the
precisamente porque
experience,
somos conscientes de los
but
riesgos
precisely because
y
we are aware of
preferimos
the risks
establecer
and
límites
prefer to
claros
establish
desde el
clear limits from
principio,
the outset
antes de lamentar
before regretting
consecuencias.
consequences.
Esta aproximación cautelosa pero
This
decidida
cautious but
ha
determined approach
posicionado a El
has
Salvador
positioned El
actualmente
Salvador
en un punto
today at an
importante dentro de
important
la
point
inteligencia
within
artificial en
artificial
Centroamérica.
intelligence in Central America.
Siguiente diapositiva.
Next slide.
¿Qué hemos implementado actualmente como
What have we
inteligencia
currently
artificial en
implemented
salud?
as artificial intelligence
Me
in
gustaron
healthcare?
mucho las intervenciones de los
I really
colegas que
liked
nos
the
antecedieron,
interventions from the
porque
colleagues
creo
who
que
spoke before us because I
dentro de la
think that in
ecuación
the
de la
artificial
inteligencia
intelligence
artificial debemos
equation,
incluir al
we
ser
must
humano y es
include
una de las
the
variables
human
que no
being,
debemos
and it
excluir.
is one of the variables we
Durante
must
este
not
tiempo, 8
exclude.
meses de haber empezado a
Over these
introducir
8 months
nuestra
since we
primera
began
herramienta,
introducing
que
our
se
first
trata de la
tool,
detección del nódulo pulmonar de
high
alto
malignancy pulmonary
grado de
nodule
malignidad,
detection,
nos hemos dado cuenta que
we have come to
la
realize
zona de
that the
desarrollo
zone of
próximo para el
proximal development for
aprendizaje
learning
es
is
muy
very
importante.
important.
Y veo que la colega
And I
anterior
noticed that the
dentro de su
previous
equipo
colleague and their
se
team
preocuparon mucho por hacer que el
placed
equipo
great
aprendiera de
emphasis
forma integral en
on
qué era lo que
ensuring the team
estábamos
learned in an integrated manner about what we were
involucrados.
involved in.
En el caso de la detección del nódulo
In the
pulmonar,
case of
llevamos
pulmonary
8
nodule
meses
detection, we
evaluando
have
una
spent 8
solución
months
comercial
evaluating a commercial solution
que aún sigue bajo
that is still
evaluación de
under
nuestros
review by
expertos
our expert
radiólogos,
radiologists,
neumólogos y cirujanos de tórax. Sin
pulmonologists,
embargo,
and
los
thoracic
resultados al
surgeons.
momento nos hacen pensar que está
However,
adecuada
the
para
results so
salir
far
a
suggest that
un
it is
programa
appropriate to
nacional
implement
de detección del nódulo
a
pulmonar para
national pulmonary
prevención o
nodule detection program for lung cancer
tamizaje
prevention
de
or
cáncer de
screening
pulmón
at the
a
national
nivel
level for
nacional
all public
para todos los
hospitals,
hospitales públicos, es decir,
meaning at no
sin ningún
cost to the
costo para la
population.
población. Estos mismos
The same
flujos de
workflows that we
trabajo que
introduce into
introducimos
clinical
dentro
practice
de la práctica
are
clínica
being
están
evaluated
siendo
for
evaluados para
commercially
soluciones
validated
comerciales
solutions
validadas por
approved by regulatory
eh,
entities
entidades regulatorias en stroke,
in stroke,
electrocardiografía y
electrocardiography,
mamografía.
and mammography.
Muchos de estos profesionales no
Many
están
of these professionals
sectorizados
are
en
not
lugares
located in
remotos del
remote
país.
areas of the country.
Y a través de esto y de
And
nuestro
through this,
desarrollo de
and through the
sistemas
development of
propios
our
y
own sovereign
soberanos,
systems,
hemos logrado que se fusione
we have
en un
managed to
anillo
integrate them into a
radiológico para
radiology network
observar
to
imágenes a
view
distancia
images
que son
remotely that are
evaluadas por
evaluated by expert
radiólogos
radiologists.
expertos. Es aquí donde la inteligencia artificial reduce los tiempos de
This is where
lectura y nos
artificial
permite
intelligence
poner en
reduces
los
reading times
primeros turnos a los
and
pacientes
allows
que
us to
pudieran ser
prioritize patients
positivos
who may
a algunas
test
de estas
positive for some
patologías.
of these conditions.
En el caso de stroke, sería determinante
In the case
sabiendo
of
que
a stroke,
tenemos
this would
entornos
be
de salud
crucial,
donde no
as we
existen
have healthcare
especialistas
settings where there are no
capaces de
specialists
diagnosticar a
capable of
tiempo
diagnosing a
un
cerebral
infarto
infarction in
cerebral
time
y reducir los
to
tiempos de
reduce
trombolisis
thrombolysis
o
or
cateterismo
catheterization
para
times
salvar la vida de nuestros
to
pacientes.
save our patients'
Sin
lives.
embargo, tal y como los mencionaba antes, todo
However,
esto está
as I
siendo
mentioned before,
observado para
all of
saber
this is being
qué
monitored
decisiones
to
está
understand what
tomando
decisions the
la
artificial
inteligencia
intelligence
artificial
is
y
making,
confirmar a través de
and to
la injerencia
confirm,
del
through
profesional
the
médico,
involvement of the
su
medical professional,
aceptación o no
whether
del
to accept or
diagnóstico que la
reject the
inteligencia
diagnosis that the
sugiere.
AI suggests.
Un último concepto que hemos
A final
introducido es el
concept we
uso
have
del Model
introduced
Concept
is the
Protocol,
use of the Model Concept
en el
Protocol,
cual hemos introducido
in
el
which we
uso
have
de
integrated
este
this model
modelo a nuestras bases de datos
with our
en un
databases
sistema que
in
es
a
soberano
sovereign,
y de
locally
desarrollo
developed
propio
system
y que nos permite hacer preguntas en
that
lenguaje
allows us to
natural
ask
a
questions
bases
in
de
natural
datos
language
sin necesidad de conocer
without needing to
SQL.
know SQL.
Esto a nivel administrativo
At an
ha
administrative
resultado muy
level, this has been
beneficioso
very
porque nos
beneficial
permite tener el análisis de
because it
datos
allows us to
masivos a
conduct
nivel del país
nationwide
con una
large-scale data
agilidad
analysis
enorme para la
with
toma de
enormous
decisiones a
agility
tiempo.
for timely decision-making.
Siguiente diapositiva.
Next slide.
Existen algunas
There are
barreras y
certain
fronteras,
barriers and frontiers,
sobre todo a la
particularly
hora
regarding the
de
evaluation of
evaluar
artificial intelligence.
la inteligencia artificial. Debo ser transparente sobre los
I must be
desafíos que
transparent
enfrentamos.
about the challenges
No
we
podemos
face.
presentar solo una visión
We
optimista
cannot
sin
present only
reconocer
an
que tenemos
optimistic
barreras
vision
reales que
without
obstaculizan
recognizing that we
el
have real
progreso en la
barriers that
implementación de la
hinder
inteligencia
progress in
artificial
implementing
en
artificial
salud.
intelligence in
La primera
health.
barrera es la infraestructura digital. Aunque la
The first
penetración de
barrier is
teléfonos
digital
móviles
infrastructure.
y nuestros establecimientos de
Although
salud
mobile phone
están
penetration is high
100%
and our health
conectados
facilities
y
are
con el uso de un
100%
sistema de
connected,
información llamado SIS
and we use
realizado
a
en el
locally
país,
developed
debemos
information
admitir
system,
que para poder mover la inteligencia
we must
artificial
admit that to scale
necesitamos una
artificial
mejor
intelligence,
infraestructura.
we need better
Además
infrastructure,
de disponibilizar herramientas de
as well as
inteligencia
to make
artificial
AI
a la
tools
población
available to
en
the general
general.
population.
Todos sabemos que actualmente muchas de
We
nuestras
all know that
poblaciones
today, many
consultan
people
la
consult
inteligencia
artificial
artificial
intelligence
antes
before
que a su propio
consulting their
médico.
own doctor.
La segunda barrera es la
The
capacitación del
second
recurso
barrier
humano.
is training of human
La
resources.
inteligencia artificial es tan buena como
Artificial
las personas
intelligence
que la
is only as
utilizan.
good as the
Nuestros
people who use
profesionales de
it.
la salud necesitan
Our
formación no
health
solo en el uso
professionals need
técnico de estas
training not only in the
herramientas, sino
technical use of
también en
these
la
tools,
interpretación crítica de sus
but
resultados.
also in the critical
La inteligencia
interpretation of their
artificial puede
results.
sugerir, pero quien finalmente
Artificial
decide
intelligence can
debe ser un
suggest,
profesional
but the final
capacitado.
decision must
Por esa
rest with a
razón hemos
trained
iniciado
professional.
programas de capacitación continua en
For that reason,
competencias
we have
digitales
initiated
para todo el
continuous training
personal de salud.
programs in digital
Y por
competencies
último,
for
la
all
tercera
health
barrera,
personnel.
y quizás la más importante,
And
es la
finally, the
evaluación
third
rigurosa de
barrier,
estas
and perhaps the
tecnologías.
most
Aquí
important,
quiero hacer un llamado
is the
específico.
rigorous
La inteligencia
evaluation of these
artificial en salud
technologies.
debe
Here I
ser
want to make a
tratada y
specific
evaluada como
request.
cualquier otra
Artificial
tecnología
intelligence in health
sanitaria.
must be
No
treated and
podemos
evaluated like
aceptar
any other
algoritmos
health
black
technology.
box sin comprender cómo
We
funcionan,
cannot
cuáles
accept
son
black
sus
box
sesgos
algorithms
potenciales
without
y
understanding
cómo
how they
mejoran o
operate,
no
what their
eh,
potential biases are,
nuestra
and whether they
población
improve
específica.
outcomes for
Lo
our
que
specific
funciona en
population or
Estados
not.
Unidos o Europa puede no funcionar igual en El
What works in
Salvador,
the
donde
United
tenemos
States or Europe
características
may not work the
genéticas,
same way in El
patrones de
Salvador,
enfermedad y
where we
contextos
have different
socioculturales
genetic
diferentes.
characteristics, disease patterns,
Esto
and
nos lleva a una
sociocultural
reflexión
contexts.
fundamental. Siguiente diapositiva.
This leads us to a fundamental reflection. Next slide.
La inteligencia artificial debe pasar por procesos de evaluación tecnológica
Artificial
en salud,
intelligence must undergo
similares a los
health
que
technology
aplicamos
assessment
a nuevos
processes
medicamentos
similar to those
o
we apply to new
dispositivos
medicines
médicos.
or medical
Necesitamos
devices.
estudios de efectividad, seguridad, equidad y
We need
aceptabilidad.
studies on
La
effectiveness,
regulación que
safety,
hemos
equity,
implementado
and
exige
acceptability.
evaluaciones de impacto para sistemas de alto
The
riesgo,
regulation we have
pero esto es
implemented
solo el
requires
comienzo.
impact
Estamos
assessments for
construyendo
high-risk systems, but this is
capacidades
only
para
the
la
beginning.
evaluación
We
sistemática
are
de
building
algoritmos
capacity
de
for the
inteligencia
systematic
artificial en salud,
evaluation of AI algorithms in
reconociendo
health,
que la innovación sin
recognizing that
evaluación
innovation
es
without evaluation is
irresponsabilidad.
irresponsible.
Las fronteras que enfrentamos incluyen también la colaboración internacional.
The frontiers
Necesitamos
we face
establecer
also
alianzas
include
con
international
instituciones de
collaboration.
investigación,
We need to
universidades y
establish
organismos
partnerships with
internacionales que nos
research
ayuden a desarrollar
institutions,
estas capacidades
universities,
de
and
evaluación.
international
La
organizations
inteligencia
that
artificial
assist us in
no
developing these
respeta
evaluation
fronteras
capacities.
y su gobernanza es
Artificial
efectiva,
intelligence does not
requiere
recognize borders,
cooperación
and
global.
effective governance necessitates global collaboration.
Siguiente.
Next,
Para concluir, quiero dejar tres
to
reflexiones
conclude, I
finales
want
que
to leave
resumen
3 final
esta visión en El
reflections that
Salvador.
summarize this
La
vision in
primera,
El Salvador.
somos jóvenes usando
First,
la IA,
we are young in utilizing
pero
AI,
somos
but we are
maduros en
mature in
nuestra
our approach.
aproximación. Debemos reconocer
We
que
must
estamos al inicio
recognize
del
that we are
camino
at the beginning
y
of
que
the
esto no
journey,
es una
and that
debilidad,
this is
es
not
una
a
fortaleza que
weakness.
nos
It is a
permite
strength
aprender de
that
los
allows us
errores de
to learn
otros
from
y
others'
construir sobre
mistakes
sus
and
éxitos.
build on their
La ley
successes.
de IA en el país y
The
nuestro
AI
enfoque
law in the
cauteloso en
country
salud
and our cautious
demuestran que la
approach to health
juventud no
demonstrate
implica
that youth does not
irresponsabilidad.
equate to irresponsibility.
Segundo, la gestión del cambio institucional
Second,
es
institutional
fundamental.
change
La
management is
inteligencia
fundamental.
artificial no es solo una herramienta tecnológica,
Artificial
es un cambio
intelligence is not just a
paradigmático en cómo
technological
tomamos
tool.
decisiones en
It
salud.
represents a paradigm
Requiere
shift
cambios en
in how we make
procesos,
decisions
en
in
formación,
healthcare. It
en
requires
cultura
changes in
organizacional
processes,
y en la relación
training,
entre
organizational
profesionales y
culture,
pacientes.
and the relationship between professionals and
Y
patients.
tercero, abrimos las puertas a la colaboración,
And third,
sabiendo que
we open the
necesitamos
doors to
aprender
collaboration,
mucho de todos ustedes.
recognizing that we have
Muchas
much to
gracias.
learn from all of you. You're welcome.
Thank you so much, Dr. Hoyas. That was wonderful. Kay, if you want to take it from here.
Sure. No, Dr. Hoyos, thank you so much for such an inspiring presentation. And I have so much that to react to, but I wanted to kind of start with two major reactions, high-level reactions. One is the entire time, I was using the interpretation feature of Zoom AI while I'm based in San Diego, and my Spanish should be a lot better. It's unfortunately not that good yet. So I was using the Zoom AI feature, and I think it was actually, pretty good from what I can tell. And I think that's such a living example in real time of how technology is allowing us and enabling us to collaborate globally. I mean, this is such a global audience, and I think it's so important that we can use these tools in the right ways to be able to understand each other and really push the ball forward in a much, much faster way. Right. So I this experience alone, I think is so telling of where we need to go and how we need to go in that path. Second is that, I was really blown away by the presentation and how much, if without context, that presentation could have been a grand rounds at UC San Diego Health on any given day, right? Just the level of depth and the similarities in terms of what we're working on, the sophistication of how you're deploying it, is actually, we are having the exact same conversations in San Diego, California, as you are having in El Salvador. So, I was just really impressed by the level of thought and intention and strategy that you're having, at the country level as well as at the health system level. So with 3 reaction points, I have kind of one is around the workforce that you mentioned. The second is around the industry partnerships, and the third is around the equity. So first, I was really I agreed a lot with your comment that training is as important, if not more important, than the technology. I do think that we need to bring everybody along for the journey. Otherwise, we're just going to increase the digital divide that was created, during COVID with digital health. And now with AI, we could have an even larger divide. At the same time, I think AI is getting so much more commoditized that we really could enable a lot more access to technologies, to knowledge, to education than ever before. And so being able to focus on literacy, digital empowerment, and really being able to say, how much are we investing in the technology versus the training and the workforce development? That was one of my really key takeaways is we often don't focus enough on workforce development and kind of the people element of the technology, because the technology itself can cost so much that it typically consumes the budget. So, Dr. Hoyos, at some point, I would definitely love to follow up, offline and just really understand how you're balancing, from a cost, resourcing, prioritization, these two elements, because clearly you're doing a lot around ensuring that the training is a key part of the larger strategy. I also was really impressed by just the breadth of use cases, from lung nodule detection. We're looking at the same exact use cases: mammography, stroke, EKG. And my question, that while you were explaining all of this, was like, how are you doing all of this? And you mentioned you have an industry partner, like a vendor that you're currently evaluating. And for me, I think that's another key point around the power of industry partnerships. I think as different countries, there's different levels of resources and startups and kind of industry ecosystems. But I do think that, even in the United States, industry is far outpacing what we can achieve as a health system. And that collaboration and the partnership, the two-way dialogue, I think is very important for us to ensure that the pace of industry is not completely misaligned from what we need as health systems, as practitioners, and as the larger patient population. So I was actually very reassured that you have that tight partnership with industry, because again, there are very few organizations that have the resources to build and train foundational models or software built on those models to deploy to health systems. And I think that all of us need to work very collaboratively together. Final point is around the equity piece. When you're talking about lung nodule detection, and I'm guessing you're looking at pneumothoraces and others, it's like, well, on one level, our biology is very much the common denominator, right? It's what's universal. Like a lung nodule, in California is probably going to look somewhat similar to a lung nodule in El Salvador. But Dr. Hoyos, you mentioned that we do have different genetics, we have different practice patterns, we have different systems, right? And so I think it's very important that you pointed that out, because as we are relying on a very few select number of companies that can build the foundational models, I think it's so important to kind of the models that you're implementing, to be able to tune and customize the algorithm, as well as the way the algorithm is used at scale in the different countries, in the different regions within those countries. And that I really kind of took away very, very strongly, because, we need to do the same thing in California and in the United States. So, thank you so much, Dr. Hoyos. I think there's just so much I learned from your presentation. And ultimately, I hope that we do have more shared frameworks. You mentioned model context protocol. I think that MCP is just one of many kind of frameworks that we can share globally, that we can then use the right tools like Zoom AI translation, others, to be able to then scale locally. And I think these kind of conversations are really just the start of, I hope, many more that will allow us to work together as a global society to advance AI in the right direction. So thank you so much.
Thank you. Next we have Dr. Frogner, and Dr. Shu is going to provide the reactor.
Thank you so much, Ivar. And it's wonderful to hear these presentations, as I think it just tees me up really well here to bring up some topics on how we can think about developing the health services research workforce to use AI. So I'm Bianca Frogner. I'm a professor and interim chair of the Department of Family Medicine and the director of the Center for Health Workforce Studies. And I've been studying who's been part of the health services research workforce in the US for quite some time. And this is really a broad range of people that we're talking about. So as I move forward in my slides, I will be thinking about research somewhat broadly, but always with a healthcare lens. So let's go ahead to the next slide. When I first thought about this topic, it felt reminiscent of probably prior conversations that have emerged over time when the internet showed up, or even when the computer showed up. So I went back just to look to see what did we do in the past, or how do we think about training up researchers? And I found a couple quotes here. One was from the American Psychology Association, or the APA. They had an advisory group on conducting research on the internet. So at that time in 2002, we were just trying to grapple with what the internet meant for research. And I found this quote articulating that research was in flux as we think about what does it mean to have the dawn of the internet. But if you go even back further in the 90s, there was a broad appearance of the computer, and there was clearly a lot of discussion around computer anxiety. And there was a recognition at that time that we are maybe creating inequities in folks because there were people who were becoming computer illiterate, people who were avoiding the computer altogether. And going back even further, when the computer even started, I think the last quote I'll come back to at the end, which is recognizing that the computer is a tool and that at the end of the day, it is people who are in charge, not the computer. And I think many of you would think that today, as you look at your own laptop, as we use things like Zoom, that these are tools. So I'm going to talk a little bit more specifically about health services research and what the potential is for AI and the workforce. So let's go to the next slide. I think already my colleagues ahead of me have really kind of pointed out the fact that AI is being used in many ways in healthcare. In healthcare delivery, we're integrating tools of AI to do better diagnosis, to better understand patterns in different tests that we're doing on folks. And what this is all producing is a lot more data. So I think one of the boons to research is that AI is a tool for collecting a lot of information. We can also use AI to pull together data from different sources in ways that maybe we couldn't have before. I think that another topic that I've seen come up many times is the use of AI in coding. I'm a health economist myself, and I've seen machine learning being used and integrated more often in data analysis. And this has been going on for quite a few years. There are quite a few special issues now emerging in journals as we think about what it means to use machine learning for mining data to try to understand patterns that are more complex than what might have initially been seen. But even not only is it about seeing patterns of recognition, but it actually allows us to also translate between different kinds of coding tools that we might use. For example, I'm a Stata user, and I like to analyze data using the Stata program, a platform. But I've seen that increasingly more people are using R, and R is free, and so that's partly why that's more appealing to younger people. More schools are starting to train health services researchers to use R. And I recognize, as much as I would love to take the time to learn how to use R, I'll probably never find the time to do so. However, AI is actually helpful in translating, much like when William Hoyas was speaking in Spanish and I'm able to read here and listen in English. I think AI can do something similar for coding, where we're able to translate one type of coding language to another, translating Stata to R and vice versa. This can be very useful to be more productive in terms of how we can share kind of how we're looking at data and how we're analyzing it in ways at a scale that just hasn't been seen before. Also, debugging, I think, has been a very particularly useful thing that AI can do, is that you can insert your code into even a ChatGPT type of machine, and it can come back and let you know what it is that's missing in your code and what's holding you up. And these are the kinds of efficiencies that we could potentially gain with use of AI. But there's other ways in which AI can also help to gain some efficiencies on what might be otherwise menial tasks, such as helping to do things like write an abstract, create high points or takeaway points that journals might ask for. It can be useful for helping with formatting or creating references. I think these are things that as researchers, we are looking for ways to save time, and AI can really be helpful for this. And at the end of the day, the hope is that maybe AI can help create a shorter time frame between ideation to publication. I think that literature reviews, as kind of indicated by Heather Ames earlier, have shown that AI can be beneficial in this way. People can draft narrative points and then have draft bullet points and have AI actually help with building out a narrative. In other words, AI can be really useful to create that first draft and maybe help refine the draft. So next slide. Now, I speak about AI very positively. I am hopeful and optimistic about the future of AI in research, and I also recognize that I think it's just here to stay. But there are some significant concerns that my colleagues have brought up in other capacities here today. One is that AI is a very resource-heavy tool. It is creating haves and have-nots. For example, just having the computing power to run some of the AI tools that we have, to run machine learning algorithms, can be very difficult. Having access to this large amount of data may not be possible for many folks who are in low-income countries, or even in settings that are just more low resource, like they do not have as many government grants to help support their work. I think with the large amount of volumes of data that is coming, it is difficult to figure out whether or not the data are of high integrity and of high accuracy. I think about how recently my colleagues were looking at a survey, and it's a relatively small survey of about, say, a couple thousand people, and they noticed that there were some odd patterns in the data, and that they could go back and look at each survey response individually to figure out what was wrong and notice some duplications in the data, and then could have conversations about what to do with it. I can't imagine going back where there may be millions of records to figure out where those kinds of misinformation might be in the data. And I think those are things that we have to think about, how to make sure that we have checks and balances on our data. I think another issue is plagiarism may be rampant. I think many educators out there are really struggling with trying to figure out how to keep up with AI tools that in the classroom, students are using ChatGPT or other AI tools to write their papers, synthesize what is being written already about health services, delivery and outcomes, and using that as part of their paper, thinking that it might be their own words or words that were created uniquely by AI, only to realize that they might be actually lifting information. I personally actually experienced something like this recently, where actually it was unintended, and I think we've at the end of the day found out that there was no plagiarism involved, which is that journals themselves are running our papers through AI detection systems. And an editor came back and asked us to please verify that our writing in our paper was actually ours, only to realize that, it was ours. We remember writing these statements, but recognize that the tool was probably running our paper on other papers that were written by our own team, because the field was relatively small and there are not that many other people writing in this area, and that maybe we were plagiarizing ourselves, something that we have to be careful of. And that takes me to some of the ethical and appropriate uses of AI in research. I think that journals and grant reviewers and institutional review boards are trying really hard to keep up with AI use, trying to figure out how best to make sure that we disclose the use of AI and how to give guidance to reviewers in writing their own reviews and to prevent the use of AI and make sure that the person is actually involved. And at the end of the day, I'm very worried that there are some jobs really at risk, particularly those who may be in the coding area, as we do see jobs like in the Amazon, Microsoft arenas, where jobs are being laid off because AI tools are coming in. So we have to really prepare for the future. So next slide. This takes me to the value of the person in health services research. Healthcare is very complex. There are many nuances, and I think it's really important that that we, as the persons doing the research, are playing an important role to understand what each community's unique needs are, and how to make sure that we take the time to understand that. We need to be the ones who are creating the important and relevant questions, and that we know who should be at the table to have the conversations, to figure out what matters to patients, what matters to the people delivering healthcare. And at the end of the day, we are the ones who are making sense of the results. it takes some critical thoughts to separate out what is meaningful versus meaningless results. It is our own intellect that can help to push back and be critical about where there might be bias and where there may be opportunities for improvement. And it also takes some clear thought to think about, what do you do with the results that we have at the end of the day? Next slide, my final slide. So how do we keep up with the AI evolution? I'll go back to my initial, one of my initial quotes, which is not to forget that we're in charge, not the computer. AI at this moment in time is still created by humans for now. There are younger generations who are coming up who are much more used to using AI. So we will have to figure out how to make sure that we keep up with them. But at the end of the day, early adopters are not just young. I have seen people of all ages really embrace AI and use it in very unique and clever ways. And I think we need to create better forums where we can exchange ideas and demonstrate to each other how we're using AI. We need to create safe spaces for experimenting with AI. And I think each of us can do that in our own space. However, I think that it's also very important that there is clear support for education and training in the use of AI. I think about here in the US, when electronic health records came about, we had something called the High Tech Act that invested millions of dollars to train a generation of users of electronic health records. And I think we could do the same to invest in future researchers in using AI to improve the health and well-being of people in the US. I know Academy Health has certainly tried to do some of this work, and I know there's an upcoming webinar in March on AI throughout the HSR lifecycle that I hope others are able to partake in. But we do need to have more of these kinds of conversations. So thank you so much for giving me a chance to share my ideas today.
Dr. Frogner, thank you very much for the really excellent presentation. What your presentation reminded me of three stories I want to share. Number one is you talked about a little bit of the history of when internet computers those came to the stage, and at that time how people felt about that. I remember when I worked for Chinese Medical Association in 1996, my first job after my college education. I was asked to manage a very large international conference. People in the office, there are 7 of them, manually using the paper and the fax to manage everybody's presentations and travels. Then I think I should use dial-up. At that time, we still dial up a number to get internet. But anyhow, I opted to use computer and dial up internet instead of fax and other things. Then I did the work for 7 people. And the people at that time was really shocked. A single person with dial-up internet and computer can do so much. So there was a sense of fear in that time because that was my first job. I think now currently the AI had some similar sensation in many places, but inevitably when we reflected on this, AI will taking the central stage. The second story is I want to reflect it is you also talked about a lot of the concerns coming with AI, in addition to the benefits. So this made me to ponder what types of capacity health workforce or researchers need to have related to AI. Of course, it's very important. We need to have the capacity to use AI, but also equally important, it's very, very important that we should have the capacity to something called commissioning literacy or algorithmic clinical governance, because policymakers and health administrators often view AI as a series of disparate apps to buy which leads to vendor lock-in or fragmented care. But we need to train our workforce to ask the right implementation questions. How do we continuously monitor this algorithm for performance drift in a local population? How do we ensure the data used reflected our community? Training the workforce to govern and evaluate AI is just as critical as training them to use it, I think. The last thing I think it's very interesting, you talk about how can we embrace AI in your last slide. This is the last day of the Chinese New Year here in Guangzhou. So today is the day we came back to work. In China, in the Chinese culture, we have a Spring Festival, Ghana. It's a TV show, which was watched by almost all mainland Chinese. And the Doubao AI, which is a AI before this, not so much well known for particularly among the older population, but they did a very clever product placement in the TV show. And now, just a couple of days, my parents, my grandparents, they are all using Doubao AI on their smartphone. It's really amazing. So that making you to think about how to make a culturally sensitive promotion and implementation for AI is very important. So AI is not only a technology, but learning from the commercial world in the way how people doing the promotion. So we can learn those in our research and also in our healthcare community. That will make a big difference, I think. But so overall, thank you so much. And I think the presentation is really enlightening and stimulative for me to think a lot more. Thank you.
As always, these presentations are so rich and we run out of time. One of the I wanted to just, in a quick summary, we talked about sort of AI with the team and the implementation of AI with a team and an organization in Dr. Ames' presentation that was so important to have us think about. One of the things that stood out for me in her presentation was the leadership and the governance that allowed them to fail. And I think as we think about the work that we're doing and the responsibility of leadership as part of AI is, what does it mean to allow our teams to fail and create that safe work environment for them to grow? And then Dr. Hoya's, he brought up sovereignty and the importance of sovereignty in the models that they are building. It's not something that we talk about often in our work, and particularly here when we're thinking about Western countries. But I think what is critically important is the opportunity that they have to be agile and move quickly. And as he said, learn from what people have gotten right and learn from where people have made mistakes so that they can move fast. And so I am excited to see where they go and the work that they do and what we used to call it reverse innovation, what we can learn from them as opposed to just thinking about what they can learn from us, because I think there's going to be rich information around the importance of sovereignty and building models that are equitable and that represent the populations that people are serving. And then lastly, with Bianca, we went to the individual level. And we talked about our responsibility as individual researchers and what it means to be accountable for the ways that we work and the learning. And I think it made me go back to Dr. Ames' work and the importance of creating the space and time and structure to allow individuals to learn. And I think as we think about how health services researchers and the organizations that evaluate their work in publications do that, how are we creating this space for individuals to learn. So training was super important. Equity at both the building level and the system and organizational level. But the wraparound of all of this was the importance of governance and accountability. And so I really thank you all for your insightful presentations. And I will hand it over to Michael to close us out.
Great. Thank you, Ivor. Before we close, we'd like to ask your help in improving webinar offerings like this. When you log off, a link to a very short 3-question evaluation survey will pop up, and we ask that you take a minute to complete it so we have the benefit of your feedback. I also want to offer a few thank yous, first of all, to our speakers, and most especially to Ivor for moderating today's conversation, to my colleague at AcademyHealth, Janae Haylett, and to Rachel Dungan for their contributions to the webinar. And personally would like to really thank our colleagues at the Alliance for their partnership in this effort. It's been great working with them. And most importantly, to all of you for joining us and engaging in this webinar. We will be making a recording of today's event available, and you will receive a link when it's ready. And thank you all so much.
Thank you. Bye.
Bye bye. Bye bye.
Adiós.